Excellent. Welcome, everybody. I'm Matt Jacobs. I'm director of the Bob Graham Center for Public Service here at the University of Florida. Thank you so much for coming out on a Monday evening. What day is today? I can't remember here. Monday evening. Thank you to all of our representatives and senators for joining us as well, and for Ed Jimenez for moderating this event tonight. We do have a few additional special guests here in the audience, so I'd like to begin by recognizing Chief Justice Charles Kennedy, who is here, as well as Jennifer Kennedy, who is also just appointed by Governor DeSantis as a member of the Florida Women's Suffrage Centennial Commission. And Governor Graham will be making his way down as well. He is here. I must say right up front, it's a real pleasure having Governor and Adele Graham here in Gainesville and able to participate in the regular life of the Senator. He's right behind me. Somebody could have told me that. So if you want to sort of sneak through this way and find a seat. Yeah. I do also want to just take a couple of very brief moments to acknowledge a significant loss for the University of Florida and the Graham Center. Many of you know David Colburn passed away about 12 days ago. He was former provost of the University of Florida. He was also director of the Graham Center, my immediate predecessor here, served for almost 7 years as director of the center. There will be a public service here at UF on Tuesday, October 8th at 2 p.m. in University Auditorium for him. And I would also just like to say how proud I am of the staff here at the center. Many folks here in the center staff worked very closely with him, some for up to 30 years. And they've had a difficult couple of weeks here, and so they've handled it very well. I'm going to speak very, very briefly. We have a hard stop at 8 because all of these wonderful folks are driving tonight, so I don't want to take too much of your time. I want to just make a quick comment on the vision of the Bob Graham Center for Public Service. We're driven by 3 central principles of civic engagement, public leadership, and public service, and equipping our students to lead moving forward, to engage, to serve, to lead. We want to help any student at the University of Florida who is so inclined to engage, to lead, to serve, to do that. As David Colburn used to say, we want to help them develop the tools of discernment that will make them effective public participants and citizens in our country and in our state. As we do that, we also want to be attuned to the fact that Florida's challenges and opportunities moving forward are the world's challenges and opportunities. And as we prepare the next generation of Florida's leaders, whether they are private employers, private employees, public servants, private citizens, whatever they're doing, we need them to be effectively engaged. We want to build a place of inclusive access here in the center as well. Again, where any student, no matter their background, can find a place to engage. If you believe in those principles of engagement, leadership, and service for one student, you must believe them for all, okay? And that's a place that we're trying to build here at the center. One of the programs through which we do this is the Tallahassee Internship Program, where every spring legislative session we send between 12 and 15 students to Tallahassee for the session, and they're placed with representatives, senators, in the Florida Supreme Court, with lobbying firms. And it's really a signature program where these students have the opportunity to experience what it's like to be at the heart of the matter, to borrow a phrase from the title of tonight's event, in state politics. And I think it's really, really important for these individuals to have this opportunity. Tonight's program is in fact a product of that. And in a moment, I'm going to introduce a student who is a member of the last year's Tallahassee Internship Program, who was one of the 2 central drivers in putting this program together. Jared Young, who was that student, was placed in Senator Harrell's office, and again was one of 13 interns in Tallahassee this past year. Julia Kennedy is the other student who was a driver behind this event. They put in an enormous amount of work. They don't know this, but they've actually created a model that we're going to try to build, where we're going to try, with a little bit more clear planning and forethought perhaps, to create an opportunity where folks who are in this Tallahassee internship may be able to, if things work out right, to be able to bring representatives and senators here to the Graham Center for Public Programming. We want to try to actually formalize that a little bit. And that's really building on the back of an initiative of Jared and Julia. And so I want to applaud you and thank you for your work on this. Finally, I want to thank our panelists and our moderator for participating in this tonight. This isn't easy. I know, again, you're all driving back tonight and have places to go. I also want to mention an additional state representative who will be here on Wednesday. Vansa Lupus will be coming and doing a student lunch and learn on Wednesday to talk about both civic engagement and children's issues. Those are two issues he's very passionate about, also doing some career development talk. So if you're a student and you're interested in that, please RSVP. You can find the information on the Graham Center's website. We do still have some spaces available for that lunch and learn. The last thing I'm going to do before I turn it over to Jared to introduce our presenters and our moderator tonight is say the way that the event will run. Jared will do the introductions and we have a moderator. This will be a panel discussion. We will open it up for Q&A at the end. We will have these cards. There will be several of us around. If you have a question you want to write down to ask, just catch one of our attentions and we'll be able to give that to you so you can write that down. We'll collect them and then the moderator will ask those questions moving forward. Finally, if you are interested in the Graham Center program, if you have not already done so, on the back table there's an opportunity for you to sign in. We can get your email address and other contact information so that we can keep you up to date on what the Graham Center is doing. Without further ado, I'll turn it over to Jared to introduce our speakers and our moderator tonight. Thank you.
Good evening, ladies and gentlemen. Welcome to the heart of the matter, a healthcare policy discussion with these legislators tonight. Participating in this panel are 4 leading members of the Florida Legislature. We have 2 senators and 2 representatives. These members serve as the chairs of the 4 major healthcare committees in the state legislature. These unique positions allow them to shape and guide the healthcare policy of the nation's 3rd largest state. We are proud to have them here tonight to discuss the future of healthcare, and we know that this discussion will give students an opportunity to learn from them. Moderating tonight is the CEO of UF Health and Shands, Ed Jimenez. He guides the strategic direction for the academic medical centers, specialty hospitals, and clinical programs. Previously, he was the system vice president for St. Joseph's Healthcare System in northern New Jersey. He's also worked at the Sloan Kettering Cancer Center in NYC and has an MBA from the Zicklin School of Business at Barrett College in New York. It is an honor to have such a distinguished host here tonight. Our first panelist is Senator Bean. He currently serves the people of the 4th District, which includes Nassau County and parts of Duval County, where I'm from. Senator Bean has remained devoted to the health care in the state during his service in the Florida House and Senate. He also works, when he's not in Tallahassee, for UF Health in Jacksonville. He's the chair of the Senate Appropriations Subcommittee on Health and Human Services, and a member of the Senate Health Policy Committee, as well as the Committee on Children, Families, and Elder Affairs. Senator Bean is also a member of the Senate Gator Caucus and the unofficial auctioneer of the Florida Senate. The next panelist is Senator Harrell, who I had the absolute pleasure and honor to intern for this past legislative session. She serves the residents of Martin County, St. Lucie County, and parts of Palm Beach County in the 25th District. The senator has over 25 years of experience in healthcare, serving as a healthcare administrator, and has served as an expert both in the Florida House and now the Florida Senate. She is currently the chair of the Senate Health Policy Committee and the vice chair of the Senate Appropriations Subcommittee on Health and Human Services, as well as a member of the Committee on Children, Families, and Elder Affairs. She's a graduate of the University of Florida, a member of the University of Florida Hall of Fame, and a member of the Senate Gator Caucus. Our next panelist is Speaker Pro Tempore Magar. She represents part of Martin County and Palm Beach County as the representative from the 82nd District of the Florida House. In addition to her role as Speaker Pro Tempore, she serves as the chair of the House Health Care Appropriations Subcommittee and as a member of the House Health and Human Services Committee. Speaker Pro Tempore Magar has served in the health technology industry and passionately advocates for better health care for Floridians. Speaker Pro Tempore Magar also serves as a member of the House Gator Caucus. Our final panelist is Representative Ray Rodrigues. He serves part of Lee County in the 76th District of the Florida House. Representative Rodrigues is the chair of the House Health and Human Services Committee. In this role, Representative Rodrigues works to ensure Floridians receive quality health care. He previously served as House Majority Leader helping guide the Florida House of Representatives and shape the policy of our state. Outside of Tallahassee, he's a community relations director for Florida Gulf Coast University. So he's a fellow academic here, and he's passionate about helping students. It's an honor to have these members here, and we're looking forward to this panel. Without further ado, Ed Jimenez.
So tonight, my job is to make sure we create free-flowing dialogue. And so we have prepared questions. I will direct them to all of you. And then, as you heard, we will also take questions. So first, I will start with Chair Bean, but this is a question for everybody. What do you see as strengths of the healthcare system in Florida? Or, alternatively, what aspects of healthcare in Florida do you believe set it apart from other states? Chair Bean.
Good evening, Gator Nation. What a pleasure it is to be with you. Bob Graham, you're here. Your place is nice. Thank you for hosting tonight. I'm shocked that it's a packed house tonight. I guess I shouldn't be. I guess for most of us, when I travel, and particularly speaking to younger audiences, they often say, you know, I'm really not into the legislature. And I say, well, that's funny. The legislature is into you. Whatever it is you do in Florida or profession, the rules are generally made in Tallahassee, which is a good thing to pay attention and be involved. And tonight, just by being here, you are participating. We're now the third largest state, and within the state budget, and we were just talking to Governor Graham upstairs, the largest percentage of money spent, if we have a pie chart of our budget, the largest percent is healthcare. And so we are constantly looking, how can we best utilize those resources to match the needs of an aging population, a growing population. And I think to answer the question, which I'm finally getting to, Ed Jimenez, is our people, our technology. We just spent the afternoon touring some of the brightest aspects of the University of Florida, which is now ranked. Let's give ourselves a round of applause for in the top 10. Number 7, that's exactly right. So we've got bright people, technology. We are collaborating. We still have a long way to go because everything's changing. It's always evolving. So we're always looking for good ideas to move the state forward to ever meet those needs.
Thank you. Chair Harrell.
Thank you so very much. And first of all, I want to say thank you to the Gator Nation and go Gators. Hey, huh? I am a dyed-in-the-wool Gator, having spent many years here at the University of Florida, both an undergraduate and master's degree. My husband received his medical education here, undergraduate medical school and residency. So we bleed a little bit of orange and blue, and I can't say how grateful I am to be here, to be back at the university, and really to have the experience this afternoon as we saw so many of the innovations that the University of Florida medical program is doing. And I think that is one of the key, really one of the leading things we are doing here in the state of Florida. And when you look at what our successes are and how we're moving forward, we are really developing a research-oriented state in healthcare. And the University of Florida is the leader in that in the state of Florida, and in fact is becoming a leader across the country. So when I really look at what the strengths of our system are, I look to see what the University of Florida is doing and the innovative, creative things that we are doing. If you won't remember this because you were not around back probably in 2000 when Jeb Bush was governor. Many of you may not have even been born yet in 1998, 2000. And one of his missions was really to change the direction of the state of Florida in education, but also in healthcare, and also in the economy, and where we focused on research. And we changed the economy from being directly just so dependent on tourism and agriculture and construction to really go to a research-oriented state and use that ability to take what we're doing in research and translate it, do the commercialization of that. No better example than Gatorade, and where you took essential research coming out of the University of Florida Medical School and healthcare and translated into an entity that has given lots of dollars to the University of Florida. So that is one of the strengths I truly believe in. But another thing I think we do in our healthcare system, and we're seeing many changes and consolidations over the years as payment systems and payment structures are changing. We're seeing a consolidation in healthcare, in hospital chains, in practice groups. But always, one of the things that I think is so important about Florida is that we have put an emphasis on putting the patient first. And for me, when I look at health policy, as a policymaker in the state of Florida, I always look at legislation to say, what does this do for or to the patient? And that is, to me, a key driver in decisions that we make at the state level, and that a great university like this, a research university, does that as well. So I am very excited about the future, very excited about healthcare in Florida and what we are doing right here as part of the Gator Nation.
Thank you, Chair Harrell. Speaker Magar.
Good evening, Gator Nation. Thank you so much for having us here. And Governor Graham, it's great to see you, and I truly appreciate the opportunity to speak with you about healthcare tonight. I think that our strength in Florida is really the people, our population. We have a large, growing, vibrant population, and with that has brought a lot of job creation. And as Senator Harrell talked about, the research that we are doing in the state of Florida is so exciting, because I believe that cures for cancer, Parkinson's, ALS, they are going to happen right here in the state of Florida, and probably right here in Gainesville. That is amazing to be a part of that. But, you know, we have challenges in the state, and part of those challenges is our population. 25% of our population are seniors. And with that comes more of an appetite for healthcare. As you age, you use more healthcare, whether it's services, prescription, insurance. All of these things add to the cost. And so with a growing senior population, that does put stress on our state budgets. And I'm Health Care Appropriations Chair, so I'm always focused more on the money side of things, and making sure that we carefully prioritize what we're spending healthcare dollars on. It's always, you know, very, it gets to your heart many times, because we are making these decisions on funding certain programs, and every healthcare program, it seems, is important. So how do you pick and choose? How do you decide where those dollars are going to go? How you're going to give a new program a chance, with shedding some dollars into a new program to see if something else works versus the way we've been doing it year after year. So, you know, those are some of the challenges that I find.
Thank you, Speaker. Chair Rodrigues.
Thank you. And let me begin by thanking Governor Graham for hosting us, American Enterprise Institute for putting this together. It is indeed a pleasure to be here, and a big thank you to you. This is homecoming week. I'm sure all of you could have found something a little more exciting to do with your first day of homecoming week than to come here and listen to us, but you're here, and for that, we are grateful. What I would say is, when you look at, let's start with the strength, and then I'll get to what sets us apart. When you look at the strength, and I'm going to agree with my colleagues, I think the strength is our people. I think the strength is the University of Florida and what we're doing here in healthcare. And I go even, a step further and say, let's look at what are the strengths of the state of Florida and see how that applies to healthcare. When you look at the state of Florida, I would go so far as to say, is one of the only states where people all over the country work an entire year to save up the money to come spend a week of their vacation here with us. We're one of the only states where people will work an entire lifetime to have the reward of retiring here in Florida. We have 1,000 people a day who are moving into our state. And why is that? Well, I think it's pretty simple. Number one, there's no state more beautiful than Florida if you look at the natural resources God's blessed us with. When you get beyond that, we've done a very diligent job in the legislature of trying to create an environment that encourages entrepreneurs by lightening the regulatory touch and keeping the taxation low. And even before us, our forefathers made sure this state doesn't have an income tax. And so the result of that is Florida is an attractive place, not just to vacation, not just to retire. It's an attractive place to come and build your career, build your business, and if you're a physician, to practice. And what we're seeing is we have some of the top experts in the entire country that are here in Florida, many of them right here at UF Health, accessible to all of you. But even outside of the campus of Gainesville, we have some of the top experts in many specialties who have chosen to build their practices right here in Florida. That's one of our strengths. And then when you get to what sets us apart, I would say we've worked very hard in the legislature to be very aggressive in working for healthcare reform. And the reform's based on two pillars. One of those pillars is transparency. I'd say three pillars. Transparency, because we believe if individuals are equipped with information, they will make the best choice. The second pillar is competition, because we believe the free market works. It works in all industries, including healthcare. And then the third pillar is quality, because what we want are for people to have access to the best healthcare possible. So, for example, in the last session, we did three major reforms. On one of the reforms, with the support of the president, we have authorized a program where we can bring in pharmaceuticals from Canada, which are much less expensive than what we're paying here in the United States, here in the state of Florida. We did that because healthcare costs are going up significantly. A big portion of why they're going up is because of the cost of pharmaceuticals, and this is a way to try to put pressure to lower that cost. We were the first state to do that. I can tell you we've already had multiple states contact us to ask for our legislation so that they can file it in their state legislatures for the upcoming session. And they're going to seek the same waiver from the federal government that the state of Florida has been given. Another example of our reform was with telehealth, to give the ability to patients to access physicians without having to physically go to their office. And that's basically recognizing where the future is going and getting ahead of it before it arrives and putting Florida at the front of that line. And then the third was the repeal of Certificate of Need, which was a regulatory program that kept hospitals from opening up until a government bureaucrat gave them the blessing. And so that constrained competition, and it actually encouraged the development of monopolies in many areas of this state where there's only one health system. Those are all major reforms. And in fact, if you compare what we've done in Florida to other states, there's no other state that's accomplished any one of those three reforms, much less all three of those in a single session. That's one of our strengths. Thank you.
Great. Thank you, Chair Rodrigues. My next question is for all of you as well, and this time I'm going to start right to left. The audience is right to left. So, Chair Rodrigues, you're back up. Take a breather. What is the most pressing issue for the state of Florida related to health care?
It's got to be the cost. When Speaker Pro Tem Magar and I got elected in 2012, we came in the same class. If you looked at the budget, the overall budget of the state, a third of that budget was related to health care. And that was a budget that, if I remember correctly, would have been about $72 billion around 2012. We just passed a budget that I believe is $90 billion, and more than half that budget is dedicated to health care. And so what we're seeing is healthcare is getting more and more and more expensive. And when healthcare continues to get expensive, that limits the accessibility that individuals have to it. And that's our biggest challenge, is bending that cost curve so that we can keep healthcare accessible to the public. And one of the things we've done within our Medicaid program is we've implemented, with a waiver from the federal government, managed care. And to my knowledge, it is the only area within healthcare where we have bent the cost curve and improved outcomes at the same time. So we know that that works. It's something that we're continuing. Phase one is over. We're entering phase two. But clearly, I believe the challenge is the increasing cost.
Thank you. Speaker Magar.
Yes, cost. Cost of services, costs of prescription, costs of health insurance. I read today that the average family is paying $20,000 for health care a year, just in premiums. That doesn't include co-pays and so on and so forth. And then to have a deductible that may be another $10,000. I mean, it is absolutely cost, and the fact that you don't know what it's going to cost. So many times, you go for services and you have no way of knowing what it will cost. It's like if you figure we're going to go out for a nice moderate dinner tonight, then you get the bill like 3, 4, 5 days later, and it's a 5-star bill. You have no idea. So that's why we talk about transparency as well. I think that you will see some of the reforms that we've made over the years, the costs coming down and driving those costs. Telehealth is a big driver that can turn costs around. We'll be presenting some studies that I've recently seen where people using telehealth have been able to drive down visits to the ER and thus costs. This study was focused on people that were big users of an ER that had visits of over 6 times a year. This is where we can make a major impact. Telehealth, in addressing the mental health crisis in this state, will also drive those costs down, because then people could access a doctor, a psychologist instantaneously online. Students here at the university, if they needed to talk to someone, could talk to someone tonight and not have to schedule an appointment 3 months down the road when the crisis may have blown up and may have led to maybe opioid trials or some other tragic event.
Thank you, Speaker. Chair Harrell, what do you think is the most pressing issue for the state of Florida related to health care?
Well, I'm going to have to say ditto. And, certainly cost is a major challenge that we face. As Representative Rodrigues said, our Medicaid budget is such a significant driver at the state level as to what we do with your taxpayer dollars. That is the largest budget item, period, of anything the state does is Medicaid. And I believe, as he said, we are making major strides with our managed care program. But also, I think we need to look beyond the cost of what things are. We also need to look at quality. And we want to make sure that we are evaluating things and changes we do and reforms we do based on quality as well. So you have to look at both things, cost and quality. But I want to get into another issue that I think is really driving cost to a large degree, and that is the major crisis we're having in mental health and substance abuse in this state. It's not just the state of Florida, it's the entire country. And unless we really start to address opioid abuse, substance abuse disorder, and mental health as really, in most cases, co-occurring with substance abuse, we really have got to get a handle on this, because we are seeing events. Many of the mass shootings that we're seeing are driven by mental health, significant mental health issues. And I think this is a turn we need to make to address not just cost, but quality of life for our patients, our citizens of the state of Florida. So as we move forward, I think you're going to see some new ideas start to come out. Integration of mental health and physical health, to me, is a key component of where we need to go. If you can combine primary care and mental health care in the same location, you can drive down cost and increase the quality of life and the longevity of life of those patients. So as we move forward, I think that's a key issue that we need to address, and it's one of the significant challenges that we are facing in the state of Florida and across the nation.
Thank you, Chair Harrell. Chair Bean.
Thank you, Big Ed. Listen, it's too easy so far. I don't want you to think that being in the legislature is easy, because It's not. Right here. First of all, Gator Nation Legislature, show of hands who would vote for telehealth. Patients should be able to see a doctor telemedically and get, yes, okay. Yeah, you can't abstain in the legislature, you have to vote. So thank you so much. You voted for it. You just passed, but wait, there are questions around telehealth. If you see that provider, if you see the provider telemedically, should the state pay the same as if you've seen that patient in person? Okay, see, there's some disagreement there. Here's the other thing, too. You want to see the top person for whatever ails you, right? You want to go see that person. Here is the big debate. Should that person that you see, should they be a licensed Florida provider that has have all the accolades and schooling and insurance that we know somebody in Florida can treat Floridians? But if you go to the Cleveland Clinic, they don't have Florida-based physicians or anybody. So that was a huge debate as to how to bring that in for a landing. We compromised and said, go anywhere you want as long as they're Florida-based or licensed to practice in Florida. They could be in Tennessee, but then we got to be able to know they have the credentials and insurance that they treat. So there you go. There's a physician or a medical provider right there. So and that's what we did. So everything up here. It sounds easy when we say we did reform, but it is. It gets kind of hairy. How about that? It gets kind of hairy in the legislature. So quiz time. If the legislature is only there for 60 days, according to our Constitution, how many bills could possibly be introduced? Well, this past year, if you guessed, over 3,500. Is that even possible? Well, the House has a new rule that if you're funding something, you've got to have a bill for it. There's bills for memorials and joint resolutions, House bills, Senate bills, 3,500. If you whittle it down a little bit further and have policy bills of substance that are similar in the House and Senate, there is roughly 1,000. And the only one we're constitutionally bound to pass is our budget, is our budget. And our budget, we don't have the luxury of being able to borrow for our budget. We have to pass, it's the only bill we're required to, a balanced budget. A balance. It has to make sense. It has to be able, we have to be able to afford it. So when they talk about cost, they're saying because healthcare is one of the largest sectors, we have to make sure that it balances and it comes in to meet the needs of all of our citizens. There's some drivers out there, as Senator Chairman Harrell pointed out. Opioids is spiking in our state. Mental health is also spiking in our state. I guess we're having, I don't know what's changed in society. Is it us looking at screens all the time? Is that what's driving us? Is it that we're more cognizant of diagnoses of mental health? But it is, and the public demands to be treated for mental health. So those are some drivers that are coming in. But the Agency for Persons with Disabilities, we have severely disabled people in our state, and the state has said we will be there to take care of your needs. And in years past, we've had budgets to provide for the needs of that population. But as of the last half dozen years, that population, that agency has run a big deficit. And when one area runs a deficit, it hurts from the entire part of that budget of healthcare. So that's something we'll have to deal with. But Ed, one last point before I turn it over to you. The cost involved with healthcare, I think, is unique to healthcare, unlike anything else out there. It's because we have a third party. We're not directly, from an individual standpoint, we're not directly responsible for the bill. If Governor Graham is going to take me out to dinner, I'm probably going to get a steak. How about that? Because Bob Graham is paying the bill. I won't see the bill. But if I'm going out to dinner, honey, would you like to split an entree? Can we see a kids menu here? Because I'm very much in tune if it's coming out of my pocket. We've got to have a way in the future, and that's where where you maybe has an idea of how we can get skin in the game. How can we get the consumer to make decisions that will affect their pocketbook? We did a bill this past year allowing healthcare companies to share in the savings if that person's combined with the transparency of making a better decision, of not picking the top price, but actually doing a little comparison of shopping for their healthcare, which we as citizens are paying for. Then if they can make a better decisions, there will be savings. And if they could share in that savings, maybe that's an incentive. We're just now exploring the possibility of doing that. But that's something long-term I see that can make the greatest difference, is to have patients being involved in the cost, or at least being made aware of the costs going forward. Thank you.
Senator Bean,
And
thank
if-
you for the
if- and if I
enthusiastic
may,
and
I'm
colorful statements. Yes, Speaker Magar.
Just want to say I agree with you 100%, and that's why I think the transparency part of that is so important. To be able to see the costs and to know what you're getting into. Now, obviously, there's always emergencies, or within a surgery, a scheduled surgery, something else comes up. But to be able to walk in and know approximately what you're paying for is paramount.
Which is why being at the Atlantic Care, or what's it called here in Gainesville?
Care Spot.
What's that?
Care Spot.
Care Spot. That's exactly right. It's a menu board. You know exactly. I'm going to see the doctor. I'm going to I'll have the number 2. That's at the Care Spot. But if you ask, it's very challenging if you go to a hospital and say, I want to get one lung transplant. How much would it cost? It's extremely difficult to do that. The transparency that we've already passed, hospitals are going to be coming online in the months to come to hopefully quantify that. Senator Harrell, add your thought.
I would like to jump into this too, as also we're getting along with this question. I think the state of Florida has been a real leader in transparency. And I think this started way back in 2004 when we were in the legislature together, and we really challenged told the Agency for Healthcare Administration to really start giving consumers, patients, an idea of what things actually cost. And we required hospitals to put up their top 100 procedures and what the average cost was for that procedure at that location. We now, and I'm very much into making sure we know what the quality is, we also now require quality measures as well to be revealed to patients. So you can make a legitimate choice in certain procedures as to where you want to have your procedure done. And when I look at the quality measures for the University of Florida, I'm coming here. So I think we're on the right track. Certainly the legislation we passed this last year really takes the next step in making sure that we have even more information out there for patients to make appropriate choices. So we're moving the bar. It's still a challenge. It's still going to be an uphill fight, but I can tell you this legislature is really committed, at least your leadership team here is truly committed to making as much information available to patients so that they can make the appropriate choices for them. And we always want to make patients at the center of everything we do.
Well, thank you. Normally the moderator's job is to channel the questions and act almost like a lawyer cross-examining, answer only the question and you're done. But I will tell you, this is the best kind of panel, an interactive panel. So we will facilitate interactivity when we can. So thank you for doing that. My next question we're going to have for only 2 of our panelists. So, I know, channeling. Chair Harrell, what is the impact of elderly populations on Florida healthcare? And how significantly does this demographic impact policy-making decisions?
Being a senior citizen, I can tell you that we are very proud of the number of seniors we have in the state of Florida. When you look at, as Chair Rodrigues mentioned, we have 1,000 people a day coming to the state of Florida, many of them choosing to retire to Florida. So they are seniors. We are a very senior-friendly state, and we want to be that way. People come to us after working a lifetime somewhere else to come here. This, however, does present challenges to our Medicaid system in that when you look at our nursing home population, and for the most part, our nursing home population is comprised of seniors. We do have some nursing homes that do have people with extreme disabilities and even children, or people who have had accidents and things of that sort. But for the most part, they are senior citizens. And when you look at the population, 65% of our nursing home population is on Medicaid. So this is a real huge budget issue for us and a challenging one. And a lot of the individuals who have come from elsewhere, so that they have not been part of our tax structure here in the state of Florida. So it does present a challenge for us to really look as we look at Medicaid and how we fund this. And that is challenging because you have federal legislation that limits and tells the state what they can and cannot do as far as looking for assets and perhaps individuals who have divested themselves of assets in order to be eligible for Medicaid. So that does present somewhat of a problem. We also are facing rising numbers of Alzheimer's. And here we're so blessed to have the McKnight Brain Institute that's doing major research in Alzheimer's. So you've got to really look and see as our population continues to age, and we're talking now not over 65, we're talking over 85, our elderly. We are now really seeing that increasing number of Alzheimer's patients. And these are individuals who are really, really in need of so many services. And we are really looking now at how we can provide the very best care in the least restrictive environments for patients with Alzheimer's. And we fund at the state level many different aspects of this. And if we can keep someone at home and not in a nursing home, the cost benefit to the state of Florida in Medicaid is huge. And the benefit to the patient being at home in a familiar environment is the best place they can be. One of the issues we find here, though, is that we get caregivers who wind up in sometimes predeceasing the individual with Alzheimer's. So this is a major challenge that we need to really focus on as we see the increasing numbers of patients in the state of Florida with Alzheimer's. Research is going to be key to really helping us deal with this. But we also want to make sure that we have programs out there to keep people in their home as long as possible and to help those caregivers who are really doing God's work.
Thank you. Speaker Magar, same question. What is the impact of the elderly population to Florida's health care?
Well, good news, we are living longer. But, 25% of us in the state are seniors. But I would say most people, I think, want to age in place in their home and not in a nursing home. There have been many new programs. There are a growing number of home health type programs, PACE programs, so that people can age in their homes with having someone check in on them, whether it's daily or weekly, depending on their needs. And being flexible with that does help save the state. And it really is about what people want to do. They want to be in their homes. A problem that I'm seeing quite a bit of is we are utilizing more and more home health care workers. But these people are some of the lowest paid health workers in the system. And they can do fewer and fewer things. They are not authorized to do things that perhaps a nurse might do, which we understand. We've had this scope of practice discussion, argument for years in the Florida House about, should nurses be able to practice to their full scope? And many times doctors have fought that. Doctors are trained in a different way and should be practicing as doctors do and taking on some of the more complex cases. But nurses for years have been fighting to sign a death certificate or prescribe certain medications. And, we have expanded that in Florida over the years, but now home health workers are challenging nurses, saying, hey, we can do things as well too, because they see if they can do more, they might be able to charge more. For instance, if you're elderly and you need to take a pill or put some eye drops in your eye, a home health worker that might be with you all day long cannot help you take that medicine or put the eye drop in your eye. They can guide your hand right up to the eye, but they cannot put those eye drops in. Only a nurse can do that. So, if we were empowering some home health workers with, of course, certifications and training to be able to do some more type healthcare work, we may see some of their job pay rising. I mean, we pay these people many times less than you would pay your babysitter to watch kids at home. So this is something that I believe in the senior population is key to helping them age in place, but there are ideas that we need to talk about within the healthcare, home healthcare, whether there's agencies that can help us with the training of putting more skilled people in there. But in the end, we've got to make sure that we've got the right trained people in, because obviously we can't send a doctor or a nurse to someone's home every day, every time they need to take medication.
Great, thank you. We're going to change gears here a little bit, and we're going to get into some provocative conversation. So I'll start with Chair Rodrigues. We've advanced transparency through legislation and through policymaking, but can there be real transparency in the state of Florida? Second part of that question. With Certificate of Need going away, we're advancing competition in the state of Florida. But will there be a meaningful move towards better and more affordable health care when we promote competition?
Let's start with the first question, which was, can we get the transparency? Quick show of hands, how many of you have visited an urgent care facility within the last 12 months? Please raise your hand. Raise them up high. Okay, keep them up. Of those of you who went to an urgent care facility in the last 12 months, did you see their procedures and their pricing when you were at the counter? About half of you did. All of you should have, because the law on that is all urgent care centers have to display their pricing of their procedures so that you have the ability to know before you go in, get treated, what the cost will be. And I would say from the data we've collected, the majority of urgent care centers in the state are complying with that law. And so what is the result of that been? What we're seeing is actually a standardization of pricing among urgent care facilities, and their prices have gone down. Why? Because if someone goes and the price is too high, they can recognize it before they've received the service. And unless it's something that requires immediate attention, and most of the urgent care visits really don't require immediate attention, they have the ability to go down the road to the next one and get the procedure done at a lower cost. And so what we're seeing are these urgent care facilities are responding to the market, and it has become more affordable. Let me give you another example. And the kids here aren't going to remember this, but us seasoned adults will. 25 years ago, an exciting new procedure got introduced into the medical marketplace: Lasik eye surgery. Prior to Lasik eye surgery, you either had to wear glasses or contacts, and believe me, it was a pain. When Lasik eye surgery was introduced, it was extremely expensive. Part of the reason it was so expensive was because it was a new procedure, and there really weren't that many physicians who had been trained on the procedure. As more and more physicians were trained on the procedure over time, what we saw was the cost of Lasik surgery went down. And it is now stabilized and is extremely affordable. Why is it affordable to go and have Lasik eye surgery where they're actually going in and cutting on your eye, but it is not affordable to go in and have other surgeries that are done in the hospital? The simple answer to that is you pay for Lasik surgery. Your insurance company doesn't pay for that. And so because it is a direct relationship between you and your healthcare provider, the prices are negotiated, they're advertised, and the market dictates. Whereas when you're going into a hospital, more often than not, you're not the one that's paying that bill. Your insurance company is paying that bill. And that is a procedure that then the insurance company is negotiating with the provider instead of you. And those negotiations always yield in higher results than a direct one-on-one negotiation. My point of giving you the Lasik eye surgery example is to show you this. If you can get to transparency, you have introduced marketplace forces. You have empowered the market. You have empowered the individual to thrive in the market, and you will eventually do two things: bring costs down, which is what's happened with LASIK surgery, and bring quality up, which has also happened with LASIK eye surgery. The challenge for us is going to be penetrating that relationship between insurance companies and providers to get that same level of transparency for the individuals. If we're successful, and ultimately I think we can be, then yes, I think we will see more transparency in the state, and we will see the same type of results, which are greater affordability and quality going up, not down.
Thank
What was
you.
your second question?
You sort of handled them both because it's
Okay.
about competition.
Then I'll
so,
move it on, sir.
So that no, you did a great job putting both together. So Speaker Magar.
I will also give you another example, which is elective cosmetic surgery, and this is very good news, where 25% of our population are seniors. So that elective plastic surgery prices are going down because people are dealing directly with their doctors, and they're seeing those prices go down. In fact, only about 6% of healthcare spending is in the ER. The rest of that spending is on healthcare services or surgeries or devices that people can shop for. And I think rewarding people, as Senator Bean talked about, insurance companies sharing the savings with patients that shop for those services is key in the future. Transparency. I think we also, to touch on something that Senator Harrell talked about, transparency in quality is very important to me. Making sure that people are able to access ratings and standards for the hospitals and healthcare facilities that they are visiting, as well as doctors, to understand that there are some doctors that have excellent positive outcomes, the highest, but guess what? They only take the best patients, the athletes, those that are healthiest. So that sometimes skews their outcomes. So I believe that when we're talking transparency, we have to know what levels we are talking about within that quality of transparency.
Great, thank you. We're going to stay on this theme, and now we're going to ask the question related to certificate of need. So the certificate of need was repealed in many ways, and the expectation is that it should affect price and accessibility to healthcare. So we'll start with Chair Harrell. What do you think about that?
Thank you very much. And talk about a controversial issue.
A little bit.
Yes, certificate of need has been very controversial, as you may know, as many of you may know. This was federal legislation way back in the 70s, long before I think any of you were born. The federal government put in a certificate of need as a process by which they could control cost. They thought if government had to authorize you to build a new hospital based on the need of the community, they could limit the numbers of hospitals in an area and only build where needed, because hospitals are rather expensive to build and also to staff, that this would cut costs. In fact, what they found out was by the 1980s, mid to late 80s, that was not the case, and the federal government eliminated certificate of need. However, states also had implemented certificate of need and have continued with it, although the federal government eliminated certificate of need. In order to get a certificate, you have to prove the need in the community. You also, and this is the issue I have with the legislation as it was written, is you also then can be challenged if the Agency for Healthcare Administration issues a certificate of need, then all the competitors who wanted that certificate then challenge you in court. And you wind up spending patient care dollars to win a lawsuit or challenge the winner of the certificate. So it created a very litigious arena and really spent millions, hundreds of millions of dollars in these fights between different entities to get that certificate of need. And what we have done is, in the state of Florida now, eliminated that for general hospitals, acute care hospitals, immediately. But for me, as a person who believes that quality has got to be there and that experience matters and the program itself matters, we put in place within that legislation the requirement that the rules that are in place to determine the quality of care, for instance, the number of patients you need to really have a good transplant program, has to be there. Those were all under certificate of need requirements. You had to prove not only that the need was there, but that there were certain numbers of patients that would be available to do those services for. And for these very complex tertiary care procedures in particular, things such as transplants, neonatal intensive care units, cardiac surgery on infants, cardiac open heart surgery on adults, these kinds of very complicated procedures that need an entire team to do and a volume of patients to do it on to keep those teams in place and in practice, that these rules stayed in place. So I was very, very careful as we moved forward with this legislation that we put those rules in place as they exist until the legislature and the department really look and see, are these rules appropriate? Do we need to change them? So we are moving forward in eliminating certificate of need, eliminating the litigious nature of it, and allowing acute care hospitals to open, but putting within it the existing rules on quality measures and requirements as far as teams go and volumes go. The certificate of need will be repealed on specialty hospitals that deal in, that are women's, for instance, women's hospitals, psychiatric hospitals, those kinds of hospitals, that will be repealed in 2 years. By then, we'll have significant experience to know what the impacts of eliminating certificate of need is. One of the most controversial parts of this, however, is that when you move forward, I was particularly concerned that you might see what's called boutique hospitals being built across the street from what used to be your community hospital. And you'll find cherry picking of very high-paying procedures, and that you would see a standalone cardiac hospital, for instance, that just did open heart, that just did surgery, heart surgeries, catheterizations, things of that sort, and really siphon off the insurance-paying patients and not take the indigents or Medicaid or low insurance patients. And that was a major concern for me, because I believe that we have a responsibility to make sure that there's access, affordability, and access for patient care. And we didn't want our general hospitals to not have that appropriate mix of patients so that they could keep their doors open. And so we continued the prohibition against boutique hospitals. So I think we have addressed that problem and the fear that was there that we would be siphoning off all the paying patients and leaving the non-paying in our general community hospitals. So I think we're walking a line in trying to make sure that there's access to care out there, but also getting rid of the litigiousness and the patient care dollars that were being siphoned off in lawsuits. And we have another 2 years to look at this, as we move down into eliminating some of the certificate of need for some particular hospitals.
Thank you, Senator Harrell. Senator Bean, with the repeal of certificate of need, what do you predict to be the impact on price and accessibility?
Ed, thanks for the question. I appreciate you. So if you're still in college right now, there's a class I want you to sign up for, and that is any class or executive communication that makes you speak or debate. Can you do that? Because you can have the best idea, but if you can't, in the legislature, if you can't stand up, defend it, or sell it to at least half the body before you, it goes nowhere. Full disclosure, I voted against certificate of need. I have wrote a couple of provisions that I thought made perfect sense to eliminate those boutique hospitals, those specialty hospitals. One is you could, build a hospital anywhere you want to build it, but build a real hospital, 100 beds or more. I also said in the Bean proposal was you have to do charity care to the same extent that your competitors are. And that's part of certificate of need now. If you open up a hospital, if one wanted to go across the street from here in years past, then they would have to match what UF doesn't say no to anybody. They do charity care. And so as part of what Chair Harrell said about boutique hospitals, it's a real concern. And so it passed. I lost. I should have taken more classes in college on debate and salesmanship is what I done. But that's the law. So we're going to go forward. We're going to monitor it and make sure that we can have. I love competition, but it's not a Publix we're talking about. It's not a grocery store. It is health care. And we have our safety net system that catches those that don't have health insurance or don't have access. There is a safety net to catch them. And the concern of certificate of need is that we lose our safety net. That being said, I'm ready to go forward, harness the power of competition so we can utilize that so patients have better choice, patients have better options, and that as a state we can go forward.
Great, thank you. This is the last of our prepared questions, so signal to start getting your questions ready. This last question is for everybody. How do research institutions such as UF inform policy-making decisions? And what resources do you draw from while making legislative decisions? Let's start with Chair Rodrigues.
I would begin by saying I think in both chambers we make a concentrated effort to make our decisions based on data. And within the state of Florida, more data comes from the University of Florida than any of our other institutions. So I would say you are influencing policy as we go through. The other thing I would say is this, and Senator Bean touched on this, if you just look at policy bills, about 2,000 policy bills will get filed in a given year. And that's excluding the appropriation bills, and those aren't bills that are matched up. That's just a senator says, here's a policy I want to do, they file a bill. Representatives get 6 bill slots. These are policies we want to do, we file those bills. And then there are committee bills on top of that. Out of 2,000 bills, roughly 200 of them will ultimately become law. So right off the bat, 90% of all bills are likely going to die, statistically. 10% are going to survive. Of the 10% that survive, if you go back and look, I would say at least 90% of them are different when they're passed off the floor than they were when they were filed in either chamber. And the reason for that is the legislative process. We file bills, and often the bills start out different within the two chambers. We're working with stakeholders in our chamber as we advance the bill. The other chambers working with stakeholders as they advance the bill. And then when we get to the end, we're working with each other. And so what I would say is this. If you see a bill that's been filed and you don't like what's in there, one, don't set your hair on fire because the odds are it's probably not going anywhere anyway. But pay attention to it. If it gets scheduled in a committee and it moves, then come and speak to the sponsor of the bill and the chair of the committee that has jurisdiction. I will meet with anyone on any bill that I'm running, any stakeholder, to get their input. And as the chair of the Health Policy Committee, I will meet with anyone who has a concern about a bill that's been placed on the agenda of my committee. But if you come and you speak to us, you can influence how that bill gets amended as it works its way through the process to become better policy. And so answer one is you're already influencing through the data that you're publishing and the data that you're giving us. And number two, if a bill does get filed that you didn't have input on and you think can be improved, seek us out, meet with us, educate us, and we'll work with you as it goes through the process.
Thank you. Speaker Magar, how do research institutions such as UF inform policy-making decisions, and what resources do you draw from to make those decisions?
Yes, UF absolutely influences the healthcare decisions that we're making through the data, through the interactions that we have with interested parties, through our relationships that we've built with Shands, UF Health, with researchers, with patients. We want to hear from all sides on different issues. Let me just give you a tip when you are contacting us. If you want to email, don't send some standard email that everyone's sending, but send us a letter or an email that's got about 3 bullets in it. That's about how long you can hold our attention. 3 quick bullets, and ask for an appointment, and then copy our aide. So come and see us. Our doors are open on policy. They have to be. I mean, we're not talking about, trading marbles or something. We're talking about healthcare. This is something that every single person in this room will need and will access. So please continue to reach out to us, and I know that tomorrow I will be on tours here at the university researching those things that I know are coming up in front of our committees this year.
Thank you. Chair Harrell, same question.
Thank you. I can tell you University of Florida is number one. There is no doubt in so many different policy issues that you all are involved in. And I can say from a personal experience, healthcare has been key in the things that you are doing here at the University of Florida and really in setting the stage for healthcare policy across the state. But also, I'll give you an example. The University of Florida College of Education, and especially special education, dealing with reading and dyslexia. Your College of Education is number one in the state of Florida in really addressing the needs of struggling readers. And what they are doing in the arena of dyslexia is amazing. And they're going to be changing where they are, and what they're doing is helping to change a key direction on how we teach struggling readers in the state of Florida. So I know of no institution that's having more impact than the University of Florida, and I take my hat off to the university, and I always say, go Gators, every time I see someone. But also, on an individual level, I think Speaker Pro Tem Magar made a good point. Those emails, oh my God. If there's a controversial issue, I have been known to get 3,000 emails in the same day that say the same thing. The impact of that is not significant. We do count them, and we put them. We have a rule we establish, and they go over in a bucket, and we do count them. We do know how many we received. But when you send an email, do not send a verbatim email that you copied off of a website, or do not go through a website. Directly send that email and make it personal. Tell your personal story. You want to have an impact. There's nothing more important than a personal story. What is that legislation going to do to you? What is that budget allocation going to mean to your child to get the right education? What is it going to impact? How is it going to impact your community? So make those stories personal and reach out to us. Every one of us will tell you our door is open. We are very interested in hearing your point of view. Just don't give me 3,000 emails saying the same thing over and over again. Thank you.
Thank you. Chair Bean.
Thank you, Ed. Just to add on, if you're going to contact us, I shouldn't have to say this, but be nice. How about that? Be nice. If if you want your email deleted is be mean. And you don't have to be mean. You can criticize the decision making without criticizing the decision maker. And I think that goes a long way. Two things I look for with research is results, momentum, and then collaboration. We have hundreds of millions of dollars that we fund, not just in healthcare, but also in education that we fund. We want to know what do we get for our money, for your money, what's happening, and so we want results. Today we toured several of your programs, and I was really blown away with the results in several different areas, from lung transplants to some things the Brain McKnight Institute's working on. That's exciting, but really the collaboration, the sharing of information, because we'll fund, this is going to come as a shock to you, for you Gator Nation. There are some monies that we do research in that go to other universities. Can you believe that? I know that's a shock, but we want to. I'm just kidding. Y'all probably had an idea about that, but we want to share that idea. I was at an event the other day where another institution says we're that close to solving breast cancer. That close. Well, if you're that close by yourself, let's collectively get everybody together, and maybe we can go that last little bit. So collectively, UF Health. UF talked about the One Florida initiative, where we're collaborating with 15 other institutions, sharing that data, and hopefully that's going to lead to some major breakthroughs, as it already has. So it's happening, and we're in the epicenter of it right here.
Thank you. I've spent time with all of you, and their answers about their pride in the University of Florida is not because they're playing to the audience. I can assure you when I visit them that they truly do see and believe that wonderful advancements are made here and wonderful thinking is here. And I think that helps give context to how they think and how they get feedback. So they were not playing to the audience. I can assure you of that. So thank you for your honest remarks. We have 4 questions. We have 11 minutes. So the best way to do this is each of you get a question. Magically, we worked out 4 questions.
Ed, we could call it the lightning round. How about that, where we all go?
Look at
Let's
that.
go.
Well,
Lightning round.
You know, so we'll do one per person. I think that's probably the easiest. So I will start with Chair Rodrigues. So I won't mention who wrote it. You know whoever wrote the question knows who wrote the question. Florida ranks 47th in the United States for healthcare access. What are we doing to improve this ranking? Chair Rodrigues.
Well, I would start by saying I'm always leery of anyone that gives me rankings, because the issue with rankings is each state may not be measured the same. Let me give you an example. I said earlier we have moved to managed care. Managed care is how we do our Medicaid. And I've seen this statistic so many times that says Florida is 49th in mental health funding. Well, that doesn't take into consideration any of the mental health treatment that is received through managed care. Because when they're doing their comparisons, they're going to state budgets and they're picking out the common line items and then ranking the states based upon that. And since we've got a waiver from the federal government that allows us to do managed care and wrap everything into one, it doesn't pick that up. So what I would say is, number one, I'm leery of anyone that says we're at the bottom of anything in this state. Number two, what I would say is, I'd reiterate what I said earlier. When Speaker Magar and I got elected in 2012, we were spending about a third of a $70 billion budget on health care. Today, we're spending over half of a $50 billion budget on health care. I think we've demonstrated that we have prioritized access to health care, and will continue to do so.
Thank you. Speaker Magar, when you speak of quality care, what metrics are most important to you in making healthcare policy? And are there other metrics you wish you had access to?
Well, if you've got those metrics, bring them on. Of course, we're always looking for data, whether it's from the University of Florida or others. But within quality of care, I talked about earlier that we have to be careful that we are measuring that quality and that we know what those measurements are. As Chair Rodrigues talked about, many times you can get anything you want from data or research. So I'm not necessarily always looking for data or backup that I want, but really the true data, which is why I look at a number of sources. So if we are looking for quality in hospitals, we might look at the CMS ratings, but we might also look at Leapfrog, which is an independent group. So I think that you have to make sure that you keep your eyes open and that the quality that you're looking at, the data that you're looking at, is broad-based.
Great. Thank you. Senator Harrell, you mentioned combining primary care with mental health care. How would both services be combined, and what would be the impact on premiums?
Well, I believe there's already a mandate under the Accountable Care Act, ACA, to have parity with mental health and health care in general, mental health as well as physical health. So there are part of your premium already, and that's one of the reasons we have seen increasing premiums, is that mental health is also included, mental health care is also included in your insurance premium. So that's already there. I think if you look at what the impact could be in reducing those premiums, I think it's significant. Because I know in running a large OBGYN practice, we also incorporated and had access to mental health professionals. We were able to avoid a whole lot of potential problems by through depression, postpartum depression, and things of that sort, and prevent hospitalization by early access to mental health professionals. The combining, and we're seeing that. We're seeing some of our federally qualified community health centers start to integrate primary care along with mental health care. And we're starting to see the impact on outcomes and what is happening for those patients. I think you will see a decrease in uses of medication to a large degree. I think you will see perhaps even a decrease in hospitalizations as you start to address mental health side of things as well as the physical health side of things. Long run, when you see that integration, I believe we'll see a reduction, not an increase, in the cost of healthcare.
Wonderful. Thank you. Chair Bean, what is your opinion of the success of accountable care organizations in Florida and their foreseeable future?
You know what? Somebody tell me what accountable care is. What is that?
You get bundled payment.
Okay. I mean,
Organized. Does anybody on the panel have an opinion on this? We welcome an opinion. Sorry, Chair Bean.
no, I'd like to defer to my colleague, Senator Harrell.
Yes, I think accountable care organizations, when you're talking about accountable care, you're talking about essentially bundled payments for outcomes, and you're going to really take a population of patients and say, how do we really make sure that population of patients is as healthy as possible, and we are paid to keep them healthy. That really, and you have an organization that gets funded wholly across a broad spectrum of specialists as well as primary care. So you're bringing a whole organization together and saying, we accept responsibility for a patient, for a whole group of patients, and we're going to help those patients stay healthy. And in the long run, the healthier they are, the more we are really going to be able to, our bottom line is going to look better, the healthier they are. And that is a good model in that you can, if you can integrate all that care and you have measures in place in order to make it work, you can do it. It's very difficult to do because you have got to really make decisions on what is in the best interest of that patient and how do I get the right care at the right time by the right person to that patient. So the incentive is to do it, and the payment comes, the incentive is that payment if you can keep them healthy. You have to be able to communicate, and without a good electronic health record, without that integration of health record systems, and a system of communication between the various providers that are looking at that individual patient and making sure they get to that right place, it can be very complicated and very difficult. Ideally, it's a wonderful concept. In reality, I'm not sure that we're quite there yet. And we're seeing this whole model start, and we're seeing hospital chains come together and large physician groups coming together to really do this. But it takes key leadership to do it, and it takes a system in place that really puts measures out there and metrics so that you can follow that individual patient. It sets protocols that makes it difficult sometimes to change practices, how we do things. Well, that may not be how I used to do it, but now I'm going to have to do it this way.
Right.
So it can really change the dynamic. But it is very complicated and a long way from perfect at this point. So I think we're going to see more accountable care coming down the road.
The
Thank you,
federal
Chair
government
Harrell.
is using that model more so than the state. The state's more of a managed care centered model.
Chair Bean, Mulligan, real quick, 1 minute or less.
But patient-centric care is key. The clinic model, we cannot keep passing patients from doctor to doctor, from specialty to subspecialty. Someone has got to take ownership of the patients and their care in order to have positive outcomes. And in the end, that saves us all money.
Thank
The
you.
patient has to be at the center of everything you do. And sometimes that doesn't happen in accountable care either. So
We should end on that. Patient is at the center of what we do. Tonight is a special night. It's rare that you and I will find the chairs of the 4 major healthcare policymaking bodies outside of Tallahassee. This is a big deal. They are here for you. It's important for you and I, as citizens of this great state, to understand where our leaders are shepherding policy. So, thank you to our panelists tonight.
Ed, thank you. Well done. A round of applause for Ed Jimenez,
All right.
our MC moderator.
Have a great night, safe driving, and go Gators.